So good afternoon, everybody, and welcome to the third and final day of our webinar. I'll just put up my slides as well. So, as you recall, we've had 3 days. We are on the third day. We had the general introduction. Then we had the somewhat more targeted 2 days ago for statisticians and data scientists. And now we are moving to the really interested, I guess. But before I get to any of that, I would like to introduce myself. My name is Thijs Lange, and I am associate professor at the University of Copenhagen. So one of the parts of the joint initiative. I will take a little time to reflect a bit on I think the general initiative and some of the methods we have proposed. But before I get to that, then let me just introduce today's schedule. In a couple of minutes, Maja Petersen will present how to use the TMLE in a longitudinal setting based on the HIV and HIV case study. I guess I said because it's such an important problem. That will be around 50 minutes, and then we will have Q&A after that. Then we'll have a relatively short break, 5 minutes or so. And then Dr. Mark van der Laan, also Berkeley, will present challenges, frontiers, and where we go from here. Which I think is a very fitting end to the whole webinar. But, oh yeah, and just housekeeping, I would like to remind all of you that if you have any questions, you can type them in the Q&A. We will moderate it. So I will pass on the questions to Maja, Mark, or other of the panelist members if it makes sense. If we do not have time to address all questions, we will answer later. Writing suitable. So yeah, do shoot if you have something. But these last couple of days, actually just this morning, I've had a couple of consultancy sessions. So maybe this is not exactly how you work in industry, but at least at the university, at the biostats department, a substantial part of our work is to be available for statistical consulting broadly. At the University of Copenhagen here, at the Faculty of Health, we have an obligation towards the whole Faculty of Health and Medical Sciences. So essentially everything that's health-related research and veterinarians, they can ask statistical questions to us. And that's a rather big part of our work and as a university-based statisticians. And I realized that we are missing a more theoretical and more structured approach to this. That was reflected in the people at Oslo University a couple of years ago arranged a whole conference on how do we actually provide statistical consultancy, statistical guidance. And it was an eye-opener to see how differently we all go about it. You can go to the website there and see some of the results from the 2018 conference. But the message from that conference was that we all do it differently, and we sort of learned on the job. And I just realized how important the roadmap could be. I mean, in some sense, it could be that structure that allows us to structure the work and our training of junior people who have to do consultancy. So just an idea. At least it will be something that I will work on with. Because as I said, literally this morning, I had 2 meetings where it was clear that these fundamental questions, where do we want to go, were mixed up with technical questions, were mixed up with very specific technical questions, missing data there, everything mixed together. and we end up spending more time trying to disentangle than actually doing the advising. So I think that's something worth thinking about. Another question that I think that's come to my mind is that it seems like as we are having more and more tools readily available, the machine learning, the broad range of different types of regression that almost anybody can do these days, essentially because the software is getting so much better. This is increasing the need for the roadmap. If I'm to try to go into Maya's amazing analogy of forests and being lost in it, then you could say that a couple of years back, a decade maybe, where most of our tools were by necessity some version of a linear slide generalized GLM type model, we were still walking in a forest, but it was more sort of a Danish forest. So that would be forest where you could still see in between the trees. You could sort of see roughly where the landscape was going, even though you were inside the forest. When you have now the element of tools available, and it's like, why don't you want to try this AI? Why don't you want to try this? And why don't you want to do this? Why don't you want to do this visualization? And essentially what has happened is that the forest has grown thicker. We are not in a Danish forest, but we are more in a rainforest now. So again, I think this is a very timely webinar, and at least I feel I have learned a lot. I've written down the links, so I'm providing it after I've done consultancy to say to people, okay, go here and you will really learn, both for statisticians and people who are much less statisticians. So I guess that was sort of an introduction to why I feel I have learned something, and why I think that the roadmap and these ideas are applicable in an even broader scale than what was perhaps indicated with our somewhat, when we have been somewhat focused on the RCT and the trials and the pharmaceutical problems, but really this is a tool that addresses so much more. So with that, that bit of a love story, I would like to give the virtual floor to Dr. Maya Petersen. So I guess I will stop sharing my screen now. And Maya, please.
Wonderful. Thank you so much for the introduction. And I love the transition from the, no, you can't hear me? Does this sound okay?
I can hear you all right.
Oh, okay, good. Thank you so much, Thijs, for the wonderful transition from the Danish forest to the rainforest. So I'll talk now a little bit, let's see. So the talk I'm going to do now with that wonderful introduction really does try to at least start on illustrating how the roadmap can be applied sort of outside some of the more basic questions with classic randomized control trials. So we really, I think, saw yesterday or even the past 2 days that even what seems like a simple question like the benefit or harm of a new agent in a well-conducted RCT already opens all sorts of questions and a need for a roadmap so we get as close to our destination as possible and don't miss key opportunities to do a better job learning from our data. So with this talk today, then, I'm going to move a little bit beyond that. In some ways, one of the easier questions, even though it still raises complications, to some more complex data settings. And to do that, I'm going to use a running case example from my work looking at HIV and really better ways to deliver treatments that we know work better ways to get them to the people who need them. So this is much more in the space of observational data, global health, and really implementation science. How do we deliver evidence-based interventions better? That said, I think it has, all of these questions have very close analogies to the pharma industry, as Henrik really outlined in the first day. I thought that was the perfect framing, that if it's a challenge we face in complex observational data in global health, it's almost always a challenge that's also faced as we try to learn more from both randomized control trials, registry data, and other data sources about the effectiveness of new agents and how they work. That said, it's always a bit more interesting to hear about a case study with just a teeny bit of motivation. So this slide is just to say that we are in the midst of one pandemic, clearly, but the HIV pandemic remains, and it continues to really exact high human tolls across the globe with a disproportionate burden in sub-Saharan Africa. This is the WHO map of HIV prevalence. They've done it by continent, but this also obviously masks huge heterogeneity within continents. Also in sub-Saharan Africa, where I work, and where the burden of disease is so high, there really are limited financial and human resources to address the epidemic, which means making the best use of the ones we have really important. My second background slide to just frame our case study is to point out that even among persons that start, that link to HIV care and start treatment, dropout of care remains very common. Occurs for all sorts of reasons, structural, logistical. There are a number of barriers to care that can arise, but this is really an important problem because when colleagues have done work tracking people or sending out folks on motorcycles to see what's happened to people who didn't come back to care, the mortality rates are extremely high. So that brings me to what I will use as a running case study in this talk. So this is an example looking at the effect of nurse-based triage, so triage of care for patients who are clinically stable from doctors to nurses, and how that impacts whether or not patients with HIV are able to stay in HIV care. So we're going to use this first to just review the causal roadmap for a point treatment effect. And you may have thought you've heard enough about that by now, but I think it's worth doing because it really lets us build the ingredients for the longitudinal questions that we want to ask. And so then next I'll extend that point treatment roadmap really to this case where we're interested in the impact of multiple treatment decisions over time, and there's also informative loss to follow up. So talk a little bit about implementation choices and show some data and simulation results. Again, I'll say this example is drawn from HIV, but the analog in both observational data and RCT settings for looking at pharmaceutical agents, it includes all those questions we heard about from Henrik on the first day, about, also from me, about what happens in a trial if you want to ask, well, what if I had been able to prevent anyone from changing therapy and somehow intervened on dropouts and also prevent switches, for example. So all of those questions about ideal regimes that involve decisions after somebody starts a randomized treatment are exactly applicable to this longitudinal roadmap I'll talk about today. So here was the question. This was an example where I wanted to use observational data to understand the impact of a program called Low Risk Express Care. So what's Low Risk Express Care? Again, it's this idea that clinically stable patients or low risk patients could have their care shifted to nurses, and that by doing that, it could be good for everybody involved. So it could free up doctor time to allow them to spend more time with sicker patients, and it could really make sure that lower risk patients may get even better care from the nurses, again, because people have the resources and time to spend with them. And so this was implemented in Kenya in 15 clinics in 2007 to 2008 as part of a USAID AMPATH partnership. And just want to thank IDEA East Africa cohorts for this collaboration. So with these data, then the question was, what was the impact on a patient of being enrolled into this program on loss to follow-up and death? So here we're considering a composite outcome that reflects both whether a patient drops out of care, whether they die, really treating that as a sort of a joint failure. So it was really unknown going into this. Was this beneficial? Was it harmful? The hope was that it did save resources, so at least it wasn't harmful, but maybe it was even beneficial. So the data available to evaluate this were really observational clinical cohort data, or pulled from these 15 different clinics. And in these data, there were a number of low-risk patients that met these eligibility criteria, and they enrolled at different times following that eligibility, where at each time point, whether or not they enrolled was not random. It was at the discretion of themselves and the providers. So with that motivation, that brings us to our familiar causal roadmap that we've seen so much of. So we'll now just step through what that looks like first for a simplified version of the question, and then use that to build out the more complex version of the question. So just to remind folks, here are the steps that we'll step through. So we're going to first specify our causal question. And here we're going to do that using the concept of counterfactual outcomes and ideal interventions or ideal experiments. Second, we'll specify our observed data and our statistical model. Again, remembering that we're really using statistical model to mean the set of possible observed data distributions. And we're going to be working in models that are big enough so that we know they contain the truth. We'll have our step of causal identification. So this process of translating that causal question into a parameter of the observed data distribution or a statistical target parameter. And be really clear about what the causal assumptions are. And then finally discuss estimation. So here we've heard a lot about the targeted maximum likelihood estimator in this webinar. I'm also going to briefly introduce today two other estimators that I suspect are familiar to many people in this webinar: the IPTW estimator, or inverse probability of treatment weighted estimator, and the parametric G computation estimator, which relies on typically parametric outcome regressions. So I'll do that because I think it's interesting to contrast the properties, and also by spending a little time with those estimators, we can understand how they feed into the targeted maximum likelihood estimator. So in our example, we're going to start by defining a time scale. So first, our baseline time point here is the time at which patients first become eligible for this program. So that's when we start the clock in our ideal experiment. For time scale, we're going to work with a 90-day discrete time scale, and that reflects really the frequency with which patients are seen in clinic, at least at that point, at least historically, if they don't drop out. Our intervention to start with is just going to be a single time point, single decision intervention. So we have this group of patients, they're eligible for the program, we start the clock, and then our intervention is just either they enroll immediately or they don't enroll immediately. So a single binary intervention at a single time point. And so with that defined, we can think of our kind of simple counterfactual outcomes. So we'll talk about counterfactual outcome under treatment or under the intervention as Y1, reflecting a person's counterfactual retention status 18 months after baseline if they had enrolled in the program immediately. and Y0 will be their counterfactual retention status at 18 months if they had deferred enrollment. So just like we've done over the past 2 days, we can then use this to define a target causal parameter. So for example, the counterfactual probability of remaining in care and alive at, or I'm sorry, flipping it around to say counterfactual probability of having been lost to care or died by 18 months if you had been enrolled immediately in the program versus you had not been enrolled immediately in the program. So moving forward then, we'll just focus on the expected counterfactual outcome under some value of the intervention, recognizing this can apply to both A is 1 and A is 0, or treatment and control. So our observed data for this problem were about 15,000 copies of, to start with, we'll discuss a simplified version of the observed data. So of baseline covariates. So this included age, sex, CD4 count, et cetera. Treatment, so this binary indicator of whether they enrolled immediately in the program, and then an outcome, whether they were lost to care at 18 months. We have a statistical model, whereas we've been emphasizing we want it to reflect our real knowledge. And so if we think about factorizing the observed data distribution into the distribution of the baseline covariates, the distribution of the treatment given baseline covariates, the distribution of the outcome given treatment and baseline covariates, we're going to be working with model that places restrictions, if any, only on this treatment mechanism or propensity score. So that brings us to our identification step. So formally, we've seen these assumptions nicely presented yesterday by David and Helene. Here they are for this simple single time point case. We need really 2 fundamental assumptions. One is, and they can be stated in terms of the causal graph, but also in terms of the counterfactual outcome. So the first assumption is this so-called randomization assumption, also known as many names. Conditional exchangeability is another frequent description. So what does this say? It says that the counterfactual outcome is independent of the observed treatment given the baseline covariates. So in other words, the baseline covariates we measure are informally sufficient to control for confounding. Now, this can be, while a nice formal statement, it can be challenging to evaluate whether it holds. Are there reasons we think it might not hold? And really challenging to bring in expert contextual and background knowledge to evaluate it. And here's a place where I think the causal graph framework really is extremely helpful. So it turns out we can also write down a causal graph to describe what we know and what we don't know about the process that gave rise to our data. And it turns out we can use a causal graph to also evaluate this assumption. So really what we're looking for in the causal graph is that we measured enough baseline covariates to block all the so-called backdoor paths from our treatment of interest to our outcome of interest. So in this causal graph, the red line is the causal effect we care about. And due to these shared common causes, they essentially open a potential additional source of association between the exposure and the outcome, a source of association that's not part of the causal effect we care about. And so in brief, when we use the backdoor criteria to evaluate whether we measured enough and what we should adjust for, this is really what we're asking is there some subset of baseline covariates in this case that are not affected by our exposure and allow us to block all the backdoor sources of association between our exposure and outcome. So that's our core randomization assumption, or the backdoor criteria. The second assumption is an assumption of sufficient support in our data. So basically just says that we need, for this particular causal parameter where we want to contrast the outcome under immediate enrollment and deferred enrollment, we need some positive probability of both enrolling immediately and not enrolling immediately, regardless of covariate values. So this is actually an assumption that's quite worth giving some attention to. because it can easily be violated simply by the way you frame your question. So to take a concrete example in this case, we would have a big problem here if there were people in our sample who were so sick that they just would never be enrolled in this triage program. They would never be transferred to nurse-based care. And that actually is an important piece when we're defining our target population. So that's one reason why in this first step of the roadmap, we said we're going to focus on a group of patients who are all eligible for this intervention. So if we have these assumptions, we can express our causal parameter as a statistical parameter. Where on the left-hand side, we have our causal parameter, our expected counterfactual outcome. And on the right-hand side, we have our so-called GComp estimand, a really classic statistical parameter in causal inference that just consists of an outcome regression, so the expected value of the outcome given treatment and covariates, and then integrated with respect to the marginal distribution of the covariates. And I'll say throughout in this lecture, I'm using a notation for discrete valued random variables just to simplify the presentation, but everything extends immediately to continuous valued random variables as well. So with that estimand, then we have three general classes of estimator we could think about using to implement it. These are propensity score or treatment mechanism-based estimators, such as inverse probability of treatment weighting, outcome regression-based estimators, such as parametric G computation, and then our double robust estimators, such as targeted maximum likelihood that we'll focus on today. So for our inverse probability of treatment weighted estimator, I think it's, again, worth reviewing this briefly or introducing it for those not familiar, just because it also is sort of gives some insight into the relative performance of the targeted maximum likelihood estimator and lets us understand some of the components that go into implementing it. So for this estimator, it's based on estimating the treatment mechanism. So in our case, the probability of enrolling immediately into the program given baseline covariates. And at least classically, this was based on parametric regression models, such as logistic regression. Now, the problem with that is that this estimator, the adjustment done by this estimator relies completely on this estimate of the treatment mechanism. And so if that's based on a misspecified parametric regression model, then the estimator is susceptible to bias. And this was a question that came up in the chat, I think, yesterday, which was, could you not estimate this with something like machine learning or super learning? The answer is yes, but it raises challenges for statistical inference. So we could be more flexible in estimating our propensity score, and there's been some nice work illustrating that at least in a number of settings, certainly can give you a benefit, but it also does mean that we've really lost our theoretical basis for statistical inference, which is not ideal. So what does this IPTW estimator look like? Here's just its simplest form, in which basically what we do is we say, okay, everybody who followed the, who didn't follow the regime of interest, so who didn't get the treatment level we're interested in, gets a 0. And the ones who did get the treatment level we're interested in, they will get their observed outcome with times a weight, where the weight is 1 over their predicted probability of getting that treatment given their covariate. So the intuition for this really is, if you have an unusual treatment level given your observed covariates. So for example, if in our example, in general, if sicker people were less likely to enroll in the program, but you were sick and you enrolled in the program, you'd have a small predicted probability of getting what you got. And so you'd get upweighted, essentially to fill in for people like you who were missing. So we take these weights, multiply them by the observed outcome, and take the empirical mean, or we can also use a stabilized version of this estimator. So this estimator has also done a long and a useful service. But it does have some substantial limitations, including really being often a high variance estimator and having the susceptibility to these positivity violations or bias in the settings of strong confounding, simply because if you get a small probability in the denominator, you can get a very large weight in an erratic estimator. So next estimator, parametric G computation. So here, what we do is we focus on the other portion of the observed data distribution. So we estimate our outcome regression, and I think for many of this is actually how we learn to do causal inference, although without a roadmap, at least in my case initially. So we estimate an outcome regression, in this case, the probability you're lost to care given enrollment in your covariates. And then we could stop there, but of course we've defined our estimand as really the marginal, the G-comp estimand corresponding to the marginal treatment effect. And so to take that initial step, we take our initial estimate of this outcome regression and then use the empirical distribution to estimate the marginal distribution of W, plug both of those estimates into that G-comp estimand, and that gives us our G-computation estimator, which in practice just means grabbing each person, using their observed covariates, using our fit of the regression model to generate a predicted value, setting the treatment equal to the level we care about, so either 1 or 0, and then taking the empirical mean of those predicted values. So this also runs the risk of bias due to model misspecification. So if we do a bad job on that outcome regression, then we'll have a biased estimate. And again, while we can think about using machine learning approaches here, statistical inference becomes a problem. So that brings us to targeted maximum likelihood estimation. First, in this, an illustration for this simple treatment-specific mean in a point treatment setting. As we heard about from a number of folks yesterday, targeted maximum likelihood estimation is really a general methodology that can be applied for a whole range of parameters. And even for a single parameter, there are choices to be made. There are different targeted maximum likelihood estimators. That said, I'll just review here one common algorithm for this particular target parameter. So the basic idea, as I think everyone's heard a lot about now, is that we use an initial estimator based on machine learning, such as super learning, to generate an initial estimate of that outcome regression. And this is really allowing us to kind of bring the full power of machine learning to bear, avoiding bias due to misspecified parametric models when we get that initial outcome regression. We could stop there and just plug in the resulting estimate to the G-comp formula, but as we've discussed, we lose the basis for the theoretical basis for our statistical inference if we do that. So instead, what we do is we take that initial estimate of the outcome regression, and then we're going to update it or target it to get a new targeted outcome regression estimate. And in this targeting step, we use an estimate of our propensity score. So by doing this, we're getting the opportunity to reduce our asymptotic bias if that initial estimator is in fact not consistent. So this is really the double robust property that we've heard about, where this estimator remains consistent if either we estimate the propensity score consistently or the outcome regression consistently. But it also importantly gives us this opportunity to reduce finite sample bias and variance. So we talked a little bit about super learning on the first day. I just will run through it very briefly here, given I'm not sure of complete overlap. In terms of what machine learning approach we use for that first step, super learning is a classically recommended one, although Mark will talk at the end of the day today about additional advances in machine learning, and we heard some from highly adaptive lasso from Helene yesterday as well. So that said, super learning is really based on this idea of setting up a competition of algorithms, including data adaptive approaches, but also potentially parametric regression models based on expert consultation, considering convex combinations of these algorithms, and choosing the convex combination that performs best, where performance is judged based on v-fold cross-validation, so internal data splits, where we partition our data into folds, fit each algorithm on a training set, and evaluate performance on the validation set and average across the validation sets. with, as Helene mentioned yesterday, the opportunity to choose a loss function that matches our problem well. So with that under our belts, then we have an initial estimate of our outcome regression. We then are going to target it. And so in this particular algorithm, we are targeting by basically on the logit scale using maximum likelihood to fit an intercept. So we do a logistic regression of the observed outcome on the intercept using our initial estimator as an offset. So importantly, what are we doing here? We're taking that initial estimator and we're moving it, and we're going to fit that epsilon. We're going to fit that shift, if you will, using maximum likelihood. The final piece of this is, though, that we're not going to give every observation equal weight when we do that fitting. So instead, what we do is we give persons' weights inversely proportional to their treatment mechanism. So again, just the same idea as IPTW, where observations that are unusual are going to get upweighted when we do that fitting. As we also heard about yesterday, really thinking about where this comes from, this model is constructed to ensure that by fitting epsilon in this way, we're going to end up with an updated estimate that solves the efficient influence curve estimating equation, which is something we want, sort of a necessary condition for having an efficient estimator. So then we get our targeted estimate of the outcome regression, and we plug it in, just as we would with the GComp estimator to get our final estimate. So some properties of this estimator, and all of this, I promise we'll get to multiple interventions. All of this is going to carry over very straightforwardly to multiple time point interventions. So some properties of this estimator, we mentioned double robustness, so consistency if either the outcome regression or propensity score are estimated consistently. Efficiency, so achieving the lowest asymptotic variance among regular asymptotically linear estimators if both the outcome regression and the propensity score are estimated consistently at reasonable rates. The ability to incorporate machine learning while still maintaining valid statistical inference, although of course that's not a free lunch, so we still really need our estimators of these quantities, the machine learning estimators of these quantities, to be as good as they can possibly be, and we'll hear about progress on that in the second talk today. And then finally, it has the nice quality of being a substitution estimator. This is helpful. It can give us improved robustness to sparse data. So there are a number of software packages available that implement this estimator for both the single time point and the longitudinal setting. So I'm just going to give some examples of one here because it's the one that's most familiar to me. This is the LTMLE package in R, and there's a vignette that illustrates all of these examples with additional text. So just to give a flavor of what it looks like to call this, it's a one-line function where you identify, in addition to your data, your A nodes, where again, we're using A to reflect the intervention, your Y nodes, here Y is our outcome, and then the level of A you're interested in. So this is how you would do just the most basic call to this function to get an estimate of the expectation of the counterfactual outcome under no treatment. The package can also do IPTW and can also do G computation using the implementations that I just described before. And then finally, you can also contrast your expected counterfactual outcomes either on a relative scale or on an additive scale. And then finally, I should note that the estimated standard errors for all of these are based on estimates of the influence curve. All right, so that brings us to longitudinal interventions. So I think with that under our belt, we're now in a good shape to talk about how could we extend all of these concepts to handle these more complex questions. So going back then to our motivating causal question, we wanted to ask about the effect of enrollment into this triage program, this low-risk express care program, on patient retention and mortality. So we started off by saying you could ask about the effect of a single time point treatment. So how was retention different if everyone, we have a population of patients who are all eligible, how would their retention and mortality differ at 18 months if they'd all enrolled immediately versus none had enrolled immediately? So this is nice. It's the effect of a decision or action at a single time point. It's easy to get our heads around. And the analog really in the RCT setting is it's the initial randomized assignment to a treatment. You control that very initial assignment, but you don't control anything that happens after, typically. So all well and good, but maybe this isn't the question that we're most interested in. So if we think about that counterfactual outcome under don't enroll immediately, it again really doesn't control anything that happens after that initial decision. It says, okay, don't enroll immediately, but then after that, really that process is left random in our ideal experiment. This says this counterfactual outcome reflects what happens to people if we prevent them from enrolling that first time point, but they still could have gone on to enroll at the second time point or the third time point. So that doesn't make it ill-defined, it doesn't make it uninterpretable, but what it might make it is not the most interesting question to ask. And this is where, again, the core first concept of the roadmap is make sure that you've really outlined your question and you understand exactly what your ideal experiment is, what your ideal protocol is, essentially, what you would do, ethics and feasibility aside, just to learn the answer to your question. So to build on that then, what if we want to know about the effect of enrolling immediately? Okay, that's fine, versus never enrolling. So now we want an intervention that actually involves multiple decisions, multiple interventions. Don't enroll in the program at the first time point, or the second time point, or the third time point, etc. So in terms of our observed data, we actually need to recognize that our observed data in this case are also more complex. So we'll keep our discrete time scale corresponding to clinic visit interval and consider then 7 discrete time points here, t equals 0 to 6. As before, we have baseline covariates that are measured at time of eligibility. So we know patients' age, sex, CD4 count, whether they're urban or rural. But now we also really want our observed data to reflect what we actually measured. And in clinical cohort data, as in many, many settings, we really also have these very important time varying characteristics of patients. So in this case, we're tracking their CD4 count over time, any changes in their antiretroviral regimen, self-reported adherence, whether they develop tuberculosis, whether they become pregnant. And all of these variables can really have important effects on both the subsequent retention and mortality, but also on decisions to enroll in the program. Our outcome now, we're going to also really now encode the fact that this is really a time to event outcome. Again, it's as we've done it here on a discrete scale, but we can now define our YT as just an indicator that you're either lost to care or have died by time point T. And then similarly, we need to respect that our intervention is a time varying intervention. So first, I'll just note I switched from A to E here, and I'll make that clear in a second. But here we're going to use ET to denote an indicator that you've enrolled in the low risk express care program by time T. So everybody starts out of it, and then this ET jumps to 1 when a patient enrolls and then remains there. The reason I say it remains there is because we really define this as an indicator that you've enrolled by time T, not that you remain enrolled at time T, although that's an extension that could also be straightforwardly incorporated. And then finally, we've got this additional complication. So now we also have a right censoring process. So right censoring here is not due to drop out of care, because that's actually our outcome in this particular example, but we did have right censoring due to 2 things here. One was that a patient could have been transferred to a clinic where this just simply wasn't available. And then the second was database closure. Database closed at a given calendar time, but baseline eligibility was across a range of calendar times. So we'll just introduce a bit of notation then that will help in the extension of our estimators to this longitudinal setting. So first we're going to separate out our observed random variables into two buckets. One are the variables that we don't, in our ideal experiment, in defining our question, we don't want to mess with how they're generated. And so these are the so-called non-intervention nodes. We're not going to change how the value of these variables is assigned based on the past when we think about our observed experiment. So here, these nodes consist of our outcome process and also our time-varying covariate process. And the typical notation that we use in longitudinal data is an overbar to refer to the history of a variable. So L bar T here is the history of these non-intervention variables, or the vector of non-intervention variables over time up till time t. And then the other bucket are the so-called intervention nodes. So these are the variables that when we think about defining our ideal experiment that would really let us address our question of interest, these are the variables where we do want to intervene to change how they're assigned a value in this ideal experiment. So this is where the A comes back and why I switched to using an E for that enrollment before. So typically we refer to these intervention nodes as AT, and they can include both things like the exposure process. So in this case, we're interested in intervening to set when somebody enrolls in this program. That's the ET, but they can also involve the censoring process. I think this is an extremely powerful way of thinking about censoring and actually missing data in general, is really through this causal roadmap that we could think about. Our ideal experiment often involves preventing missingness in some form, preventing right censoring, ensuring everybody's measured. So we can use the same causal framework to think about defining counterfactuals, where we not only intervene to assign treatment the way that we're interested in, we also intervene to prevent right censoring or to prevent missingness. And this is, again, like most of the good insights from the causal roadmap, that's not a novel way of thinking about censoring, but what linking it to the roadmap does is it allows us to do things like, for example, use causal graphs to assess what variables we would need to adjust for in order to, for example, control for informative censoring, and then use this process of identification to translate that into an estimand or a statistical parameter that we may not have landed on otherwise. So in this example then, our intervention nodes are the exposure nodes and the right censoring nodes. So now here's our more realistic observed data structure, where we have our 15,000 copies corresponding to a vector of non-intervention nodes over time, where those include the outcome process, and a vector of intervention nodes over time, where those include the exposure and right censoring process. So again, we can factorize the distribution of our observed data. Just like we did before, we can factorize it into components that involve the treatment mechanism or the conditional distribution of treatment given the past, and components that involve the conditional distributions or densities of the covariates given the past. And again, we're going to be working in large statistical models that place restrictions, if any, only on the treatment mechanism. So we need a target causal parameter then. So what do these parameters look like when we now get into the case of multiple interventions? So we're still going to focus, just for illustration, on, as an outcome, this indicator of being lost to care or died by 18 months. And so what we now like to ask is, how would your counterfactual probability of having been lost to care or died by 18 months have differed if you first had never enrolled in this program? So your E-bar vector, your exposure vector is set to 0. That decision at every time point is 0, and censoring was prevented. So that's this first expectation of the counterfactual outcome here. Just to keep our notation reasonable, we'll just refer to that as the expectation of the counterfactual outcome at time 6 under this intervention to always set enrollment to 0. So just abbreviating that as a 0 bar. And then we can do a similar thing for enroll immediately and prevent censoring. And so now we can talk about a new version of an average treatment effect, where we're still contrasting expected counterfactual outcomes on an absolute scale, but now these counterfactual outcomes are really indexed by interventions at multiple time points. And you should be able to see here, so I've done one extension to include interventions at multiple time points and prevent censoring. But you can also start to get a flavor of how flexible this framework is. So when you define these ideal interventions, really you just need to say, what are the ways in which I want to set exposure, missingness, et cetera, at every time point in order to answer my question, in order to define my ideal experiment. And if you can say what it is you want to intervene on and how you want to intervene, then you can define these counterfactual outcomes and then contrast them however you want in order to quantify your effect of these different longitudinal regimes. That brings us then to identification. So in terms of identification, the problem also gets harder in this case, and we saw a preview of that on earlier days. So the core of the problem here, I've just boiled it down to kind of the basic causal graph. Clearly, the observed data structure that we just discussed would be a more complex graph involving more time points, as well as a right censoring process. But I think this graph serves to make the point, which is that a really core difference when we go after these longitudinal effects is that we're interested in the effect of multiple treatment decisions over time. So in this case, for illustration, the effect of enrollment at time 0 on the final outcome and enrollment at time 1 on the final outcome. Importantly, though, in these longitudinal settings, often we have cases where part of the effect of that early enrollment decision on that final outcome is mediated by these time-varying intermediate variables. So for example, whether or not I enroll at the first time point might affect my health at the second time point. And my health, and that can be also important in terms of determining my final survival. So we have a causal pathway here. But importantly, my health at this post-baseline time point can also act as a confounder, because it can also determine whether or not I enroll at the next time point. So patients, for example, who don't enroll and become sicker may be much less likely to enroll. And so this is this variable is sort of classically referred to as a time-dependent confounder. This exact same structure, as we've heard about a little bit, can come up with right censoring as well, where we're in a setting where earlier treatments affect intermediate covariates that then go on to affect both whether a patient drops out of the study as well as their outcome. And so we really need to control for these time-varying covariates to adjust for informative censoring, but they're often affected by earlier treatment decisions. So this exact same sort of causal graph and then solutions can also apply to that case. And indeed do in this particular example where we have both right censoring and enrollment. So we've got this conundrum. We introduced before this idea where if we can look at our causal graph and find some set of covariates that lets us block all these backdoor paths with arrows into our exposure variables, if we can somehow find all those and condition on those, adjust for them in some way, we can remove the sources of association between our exposure and our outcome that are only coming from these shared common causes, these confounding pathways. The problem is in this longitudinal setting that there is no such one set of variables. Instead, we have this guy who's really, we need to condition on this variable in order to block the confounding here, this source of association between enrollment and the outcome. But we can't approach this in the usual way because this is really affected by earlier exposure. And this was really, this is a longstanding problem across many fields where our work by Robin in the early 80s really opened a path forward to address this. So the core insight here is that instead of tackling this all at once, we basically break it into parts and tackle it in turn. And that leads us to the sequential randomization assumption. So sequential randomization really just does the same thing we did in the single time point case, but applies it to this multiple time point. And we can also similarly apply an extension of the graphical criteria to this multiple time case. So what we do essentially is for each of these intervention nodes in turn, we say, okay, first for baseline, is there some subset of the observed paths that I can use to block all of the paths between this exposure and the outcome that are not part of the effect I'm interested in? And so in this case, yes, I can condition on W0, and that'll block this source of association. Then I move to the next time point. I say, I'm not trying to do it all at once, I do it in series. So at this next time point, is there now some subset of the observed paths that will block all of the association between this time point and the outcome? That's not what I'm interested in. And indeed here, now we can use this whole past. We also have an extension of the positivity assumption to this case. And so in terms of positivity, it's really the exact same idea. It's just that we now need this to hold for every time point that we're intervening on. So for every time point we're intervening on, we need some positive probability of following the regime of interest, given you followed the regime of interest so far. So if we're looking at not enroll, given you haven't enrolled so far, irrespective of your covariate history so far, you need some positive probability of not enrolling. And we need to hold that to hold for all of our regimes of interest. So in this case, we need it to hold for enroll immediately and don't be censored, and never enroll and don't be censored. So again, this is a point where it's really important to give careful thought. So in this longitudinal case, for example, even though we started off with a target population where everybody was eligible for immediate enrollment, in this case, if we might have, as we move forward over time, some patients who lose eligibility, who become too sick to enroll. So that would mean that such patients would have no probability of enrolling. And so we wouldn't be able to look at regimes like enroll 2 time points after eligibility, because we'd be opening up this door to saying, yes, but patients who lose eligibility during those first 2 time points now have 0 probability of enrolling at that 3rd time point, for example. So that would be a violation of this positivity assumption. In our case, though, we've defined these 2 regimes kind of deliberately to avoid that. So the first one says enroll immediately. And that, by definition, everyone is eligible to enroll immediately at the start of this follow-up. And the other one says never enroll. And so for never enroll, it's not a problem if you lose eligibility. You still have a positive probability, in fact, a deterministically positive probability of enrolling, of not enrolling at future time points. So under this sequential randomization and positivity assumption, we can look at the generalization of that single time point G computation formula. And this is the so-called longitudinal G computation formula. Really, the idea is exactly the same. So we've got here our expectation of our outcome, given that you followed the regime of interest. So you either never enrolled or always enrolled immediately, and given your covariates. But then the difference is that we integrate with respect to the post-intervention distribution of the covariates. So in other words, at this step, we're really recapturing what the values of those covariates would have been under the regime of interest. So we don't lose that aspect of the effect that's mediated by those intermediate covariates. So with that estimand in hand, we can think about these exact same estimators. So I'll first look at parametric G computation and IPTW, and then extend it forward. So the parametric G computation estimator, just like in the single time point case, is based on estimating the non-intervention factors of these observed data distributions. And essentially you estimate them and then you simulate from them, which is nice and intuitive, but is susceptible to bias due to model misspecification. In terms of the inverse probability of treatment weighted estimator, again, it's really exactly analogous. The 2 differences are really just that now we have our treatment mechanism that consists of both probability of enrollment at each time point and probability of remaining uncensored each time point. So we need to estimate both of those. And then of course, it's now becomes a product over time because there are decisions being made at multiple time points. So just like in the single time point case, We could estimate this treatment mechanism, so our probability of enrollment given the past, our probability of censoring given the past, using parametric regression models like classically logistic regressions. But once again, we run into this issue of bias due to model misspecification. And while we can also employ data adaptive or super learning methods, as we noted in the single time point case, it raises challenges for inference. So finally, then, that brings us to the extension of, one possible extension of TMLE to the longitudinal case. And before I introduce it, I just want to first introduce a different way of writing the longitudinal G computation estimand. So in terms of this estimand, this is, we can take that original G computation formula and we can re-express it in terms of iterated conditional expectations. So we've just rearranged that same guy from before, haven't changed anything. So why is it worth doing this? Basically, the idea is that by re-expressing the estimand this way, it opens the door, or it immediately suggests an alternative approach for both parametric G computation, but also double robust estimators. So really what we've done is we've changed our prior estimand, which was a function of this regression object and this series of conditional distributions and densities. Instead, we've just re-expressed it as a form of nested regression objects. And so that's nice because what we have here are nested regression objects. We have on the inside that same expectation of the final outcome given you follow the regime of interest in the past. And then we take that object, take its expectation given a time reduced past, and iterate outwards until, or not iterate outwards till we get to the outermost expectation. So why would we want to do this? It really gives us potentially an easier set of factors to estimate well. They can be lower dimensional and have been, basically we've turned the problem into a series of regressions. So we can implement an estimator in that way based on just estimating these series of nested outcome regressions. So first we estimate the inner one, then we generate predicted values evaluating at the treatment regime of interest. Then we use those predicted values from the first step as the new outcome in the next step, regress on now the time reduced past, generate predicted values again, and repeat until we get to that final time point and take the empirical mean. So finally then, that brings us to the longitudinal TMLE estimator. And I know we are at the top of the hour. I think we actually have a little bit of extra time in the second hour from the schedule Thais showed. So I'm going to wrap up this longitudinal TMLE and simulations. Then I think we'll take a break and do questions after break before going to Mark. So finally then, that brings us to the longitudinal TMLE estimator. So again, these properties that it has really carry over from or analogous to the properties in the single time point case. It has this nice double robustness property. It's efficient in this large statistical model. It can incorporate machine learning while retaining inference, and it's a substitution estimator. So what does it look like for, or at least what does one particular TMLE algorithm look like for this expectation of the counterfactual outcome under multiple time points? Here we can just bring together that basic targeting approach we learned in point treatment with this iterated conditional expectation approach for the regressions that we just saw as a way of re-expressing our GComp estimand. So basically the idea is that we use an estimator that's exactly analogous to our iterated conditional expectation G-computation estimator with just two key differences. The first is that when we think about estimating each of those nested outcome regressions, we can and should bring in machine learning. So for each of those nested outcome regressions, we want to estimate them as well as possible, and we can put machine learning to work for us. The second is that at each step, before we move on to fitting the next conditional expectation, we just do an update step, a targeting step, where we update that initial fit. And the approach to targeting is exactly analogous to that single time point targeted maximum likelihood estimator. It uses an inverse propensity score weight and confers the same potential advantages as in the single time point case. So a quick feeling for what that looks like. We'd start by estimating the innermost conditional expectation using superlearning, then update our initial estimate just as for the single time point, using maximum likelihood to fit an intercept-only logistic regression with our initial fit as an offset, and then these inverse weights, where now the inverse weights incorporate the whole treatment mechanism over time. And again, this treatment mechanism can be estimated using superlearning. And then we repeat for that next nested regression, et cetera, until we get down to the last time point and take the empirical mean. So this is also implemented in the LTMLE package, where we have some A nodes or intervention nodes, C nodes to indicate right censoring. L nodes in the package syntax are used for time-varying covariates, and Y nodes for outcomes. And so this is just to show you can use that same call now for longitudinal interventions. So here we're saying now we want to intervene at 2 time points, A1 and A2. And the intervention we want to do is to set them both to 0. We can also integrate right censoring. So censoring nodes, again, are called C nodes. So we just tell the package, these are the treatment nodes, these are the censoring nodes, these are the time-varying covariates, these are the outcomes. And then this is the intervention that I want to do on the A nodes. I want to set it to 1 and then to 0. And then finally, the package also calls superlearner, and then you can you can either use a default library or, as is recommended, choose your own library to flexibly estimate both your outcome regressions and your propensity score. And just as in the single time point case, we can output effect estimates at the absolute or relative scale. So just to conclude then, I'll show a result of a simulation and then result of the data analysis. So this plot is plotting MSE on the y-axis and time on the x-axis. And the key thing about time here is as we move forward in time, we estimate the expectation of the outcome at later time points. The potential for positivity problems increases because we're taking a product of the treatment probabilities over more time points. So I think the key take-home point here is, so here's our GComp estimator with correctly specified parametric models. So as we expect, it does well throughout. The real point, though, is that we, in practice, not simulations, never really know enough to do these correctly specified parametric models, and so we lose our basis for inference. Here, for example, is the IPTW estimator showing how MSE increases as positivity problems increase, again, using a correctly specified parametric model. And then finally, here's the TMLE estimator described here, which does pay some price for working in this larger statistical model, but really performs quite well. And then finally, what did the data analysis look like? So here, of course, it's a real example, so we don't know the truth. But in this example, we would expect that in the unadjusted estimator, patients that never enroll are generally the sicker patients. And so if we adjust effectively for that at both baseline and over time, it should shift this bottom blue survival curve up. And indeed, that's what we see when we implement this TMLE estimator. So it's at least consistent with better control for confounding. It's true that patients who become sick are less likely to enroll as we expect. So just to conclude, with many thanks, we have these longitudinal targeted maximum likelihood options, integrating machine learning to go after both expected counterfactual outcomes of these longitudinal regimes, but also a whole range of more complex parameters like dynamic regimes and marginal structural models. That this offers the potential for real benefits, but as we'll hear from Mark coming up next, care really is needed. So there are a number of things that can go wrong with this approach, just as with all statistical estimation approaches. A few key ones are making sure that there's sufficient support and getting into these settings for marginal support of specific treatment regimes. The risk of overfitting your initial outcome regressions and what we can do about that. And then finally, working to ensure convergence rates of your machine learning based estimators. And so that is what Mark will be talking about coming up next. So I will conclude there. Let's take 5 minutes and then come back, and if that's all right, Thais, and do a Q&A after a break. I feel people might need a bio break, so would that be all right? All right. You're muted. So, all right, let's take a 5-minute break and we'll come back and do questions before moving to Mark. Thanks.
Perfect. Thank you, Maya. 5-minute power break.
Hey, Maya. Can you hear me?
Here we go. Yeah, I made that long because we had extra time because Kajsa is not concluding. So.
Okay.
Hello. Can you hear me?
Let me see. Am I muted? No. Can you hear me?
No, I hear you. I hear you. Do you not hear me?
Yeah, I hear you now. Yeah.
Okay.
Can you see my slides? Or let me see.
Yeah, I see your slides. Yeah.
Okay. So I need to. Wait a minute. I guess window full screen. Let me just make sure. Does this look okay?
Yeah.
Okay, good.
So I know I did overtime, but it's because our schedule had shuffled. So I thought I would leave half hour for you.
So how much time do I have? Did you say?
You should have half an hour. If we come back at a little before 8:15 and do say questions to 8:20, then you have still a half an hour with plenty of time for questions.
Okay, now that's more than enough. So.
Yeah. I just went slow because we had a shuffle in schedule, so I was going slow.
Oh, so normally Thijs would have talked more, or?
No, we had it was sort of a last minute thing. Thijs was perfect, but yeah, just so you know, I wasn't completely ignoring the time.
Hey, it was great. Very clear.
Yeah, so you should take your time. You for sure got half an hour.
Okay.
No questions though. Oh dear.
So, welcome back, everybody. And now I can get to say thank you, Maya, for a nice presentation. I have a few questions I got on email, but I would also like to open the floor in general. If there are other questions, you can mark it in the Q&A. But the first question I had, and I guess it's a general question, but one could refer to your slide, Maya, on sort of the mean square error as you move across time. And it's an lived experience where a binary outcome was analyzed with the TMLE. So I guess we can think of it just as the time one part. That must be, if we only look at that part. It was analyzed with TMLE, number of covariates, and then the IPTW was performed as well as a sensitivity. But then it consistently showed that the IPTW was more precise in the sense of narrower confidence intervals for the parameter of interest. Is that something you say, of course, or too bad, or are we to expect stuff like that?
Well, maybe the first, I'll have a pass, and then maybe Mark can have a pass as well. I mean, I think my first question is, this was a simulation or real data?
Real data, real data.
So one thing that can happen with IPTW is if you get to areas where so positivity is one potential explanation. So if you have a setting where there is, for example, one sick person, in my example, one very sick person who enrolled in the program, that one very sick person would have a small predicted probability and a big weight, and IPTW should get big. But if in your finite sample, you ended up with no such person, right? So you've got a positivity problem, a practical positivity problem, but you've got nobody there to be upweighted, then you can really have a problem in terms of bias. And that's not going to show up in terms of increased variance. So I think that's one thing that can go awry with IPTW. It looks like this very nicely behaved low variance estimator, except that it's biased because of positivity. So that can be an issue. I think the other things that I would want to know are how are the weights being estimated, and how are the nuisance parameters and treatment mechanism being estimated for TMLE as well? Because you can also, if you're essentially working in a small statistical model because you use a low dimensional parametric regression for your weight, that can look lower variance, because you've essentially forced your statistical model to be smaller by working with this kind of like simple weight model. And if you kind of make it unfair by having TMLE work in the much larger statistical model where you're using the full power of machine learning, I would say that would be another way in which you might be comparing apples and oranges. But that's a couple things that jump to mind. I don't know, Mark, do you want to comment on this question as well?
Yeah, so generally speaking, I would recommend to do a little simulation imitating your data analysis, right? You can fit your treatment mechanism in your regression and then simulate and see the behavior of these estimators, because then exactly the kind of issues Maya was pointing at might pop up, such as indeed that, sometimes there is positivity violation, but they don't show up in the data because the weights are, the unlikely events just don't happen, even though they do cause bias. They are not showing up as large weights. Again, how do you implement TMLE? I presume this is using the standard TMLE package.
Yeah, it was pretty.
Yeah, so then, I mean, there are different ways of implementing TMLE, and that one puts it in the weight. That's actually pretty robust, so that should not explain why it would be more variable. The other thing is gain of efficiency of TMLE comes from doing a good job on the outcome regression. So that's something, I don't know how you did it. I mean, how you fitted the outcome regression. Did you do a good job, right? But if there's, for example, essentially gain in efficiency has a lot to do with gain in R square, right? How much are the covariates helping to improve your predictive power for the outcome? In particular, in a randomized trial, that's precisely where the gain in efficiency comes from.
And if they don't, there will be no gain.
What's that?
And if they don't predict very much, there would be no gain, perhaps
exactly.
even a
Like
price.
Exactly right. For example, in a rare outcome situation, there is no gain in efficiency, right? So it's purely bias you worry about. And that's where TMLE can still be helpful by having this double robustness and therefore have more like quadratic bias instead of just bias only due to G. But you're not going to get a gain in efficiency, even in a randomized trial. So absolutely right.
Okay, thank you.
But
I guess it was also okay to
much
take
more about the situation you're in. But
no, but I guess also the simulation advice is generally good. That you should remember that. Yeah. There's a question in the Q&A. I'm just going to read it out loud. Hi Maya, thanks for the great talk. I'm wondering, is the framework of LTMLE and sequential regressions also applicable for randomization on community group levels? And I guess you can broaden the question a little bit to all these kind of, there is something nested going on, or that these kind of issues. What do you think? How do we address these real life challenges?
Great question. So I guess briefly, yes. And one thing I'll note about the LTMLE package as well, just because I happen to highlight that one, is it is able to handle hierarchical data as well, in terms of providing influence curve-based variance estimates, where you provide the independent ID variable. So, for example, the community or the cluster, for example, and then that information is accounted for in the influence curve-based variance estimate. So the short answer is yes, and that is an option in the LTMLE package. The longer answer is that I think when we get to these cluster randomized or more general hierarchical data settings, in addition to them being longitudinal settings, all sorts of additional complications and ways forward can arise. And I think this is an area of really exciting active research. And so there's a number of papers that we can just put up on the website where people are working through this problem. To note just one example of work done by a former PhD student that I think is particularly sort of exciting and relevant to this question is this idea that in a pair-matched randomized trial, for example, as we've done, you really are working with a very small number of independent units. You want to get something out of your adjustment, but you're really limited in how much you can adjust. And so this idea of taking this, using TMLE and using data adaptive approaches to choose the adjustment variable, especially in a cluster RCT, that gives you the best precision is, I think, a really important one. And she's done really nice work showing that you can use essentially a cross-validated variance estimate to compare different adjustment variables and select those in a rigorous way to get more power out of your cluster RCT. And so I think a lot of potential for that sort of work as we think about applying these methods to especially the smaller cluster RCTs, or the RCTs where there are fewer independent clusters.
Thank you. I think that's, in general, it's going to be a bit of a challenge when we are suggesting something quite new, is that all these additional tools we have developed for this or that particular solution in a problem in a regression, are they still applicable? But that's as you say, it's going to be a future research. I will have to cut the questions now. So we will move forward to Professor Mark van der Laan's talk, Challenges and Advances for Longitudinal TMLE. Mark, please take it away.
All right. Yeah, thank you. Yeah, another paper comes to mind, is Mireille Schnitzer, which also did a longitudinal analysis where she had to work with the cluster structure. But anyway, we can put that up. Okay, yeah, so I will talk about some challenges that, I mean, careful thought is necessary and being warned what can go wrong, particularly in these kind of longitudinal TMLE. And I will talk about responses to that as well as advances. So here's a little overview. We'll talk about the danger of overfitting the initial estimators. We talk about how to build a powerful superlearner, how to deal with positivity, and then some problems with the current sequential regression TMLE and how we can come up with another type of longitudinal target maximum like the estimator, and that's also work in progress, and we'll talk about that. And then finally, I will talk about a topic I've worked on over the last half year, and we'll talk a little bit about that. Okay, so first thing to realize when you do TMLE, and that it's not just for longitudinalism in general, if your initial estimator, so like your outcome regression, is overfitted, so that means there's little signal left in the residuals. Yeah, the TMLE works with the residuals, right? It uses the initial estimator as offset and says, okay, let me now see, fit that clever covariate with the epsilon and to get my bias reduction. And that has to do with, and if then the initial estimate is an overfit, there's very little signal there. So you don't really get much of a change. And that's why we, at the time, we saw that, for example, when you use random forest as your initial regression. That's a machine learning package where you can see there are nowadays, more careful implementations which are better tuned, but the typical standard one, you can check that if you look at the empirical R-square of the random forest or the cross-validated R-square, that they're very different. Right? You might see a cross-validated R-square of 0.25, even though the empirical R-square is 0.7. Meaning it's really just doing a lot of extra fitting without any gain in performance. And these are dangerous algorithms for the sake of TMLE. And that's why we, in most of our applications these days, but not in all software developments, but we are trying to get implemented the so-called cross-validated TMLE. For example, in the TMLE package for point treatment, that's implemented and more. Which is the idea is that you apply the initial estimator, like the outcome regression, on the training sample, like 9/10 of the data, and then you do the targeting on the validation sample, and then in that manner, when you do the little extra fitting of the targeting step, the epsilon in front of the clever covariate, that is then getting its full power, because it doesn't matter that the initial estimator is overfitted, because you have now separate data to really still get the full bias reduction. And then you can then do it in 10-fold. So you get 10 of such targeted estimators, and therefore really 10 TMLEs, and you take the average of them. And then you can even, instead of doing the targeting separate on just the validation sample, you can actually pool across the targeting in one step and do the targeting based on a total cross-validated log likelihood. Anyway, so that's something to be aware of. Sequential regression in this longitudinal target maximum likelihood story requires particular care, since in that case we start running this regression first of the final outcome given the past, and then the next given the past, and so on. And the ones you start out with are at the end. So these are only conditioning on the people who are still in your sample, so who haven't dropped out yet and actually have also followed the regimen. Which is of course a long regimen at that final time point. So that means there are many fewer people still following your regimen and haven't dropped out yet. So meaning that you are actually fitting that regression on a relatively small sample potentially. And so there, if you then still use the same, aggressive machine learning, or maybe you throw in a linear regression with many covariates, even though they might make sense for the earlier the regressions at earlier time points, they are just overfits for the final time points. And so that's why, again, you have to be very adaptive how you choose your machine learning algorithm, even as you move across time, because they should be very much based on the sample size, the effective sample size you can work with. That's also a reason why many of the machine learning algorithms, at least we like to use, are also using screening. So that we don't necessarily give them 1,000 variables. We might do some kind of variable importance, like that could be based on things like univariate regression, but it could also be based on some kind of lasso, or even a random forest has a little variable importance measure. And then you can rank the variables in that manner, and then only choose the top k variables, and then you might have different algorithms like that in your superlearner, indexed by how many, what the top k variables in it, how many variables are you including before you run that machine learning algorithm. So that helps to make the algorithm less overfit and actually more effective. Okay, so this also gets into that part of TMLE is to use, typically we like to use superlearners because then we don't have to bet on one algorithm. So we don't have to say you should not use parametric regression, or you should not use random forest, or you should not use this. We often don't know a priori what's the best algorithm for this particular application, and that's why we like superlearner, because then we can build a library of all these algorithms which we think might be reasonable, and then just have a competition, an honest competition, decide what should be used in your data set, and that's all through an a priori specified superlearner, which is defined in particular by the library of algorithms. And so, but how powerful your superlearner is depends on your library. And so it is important to put good algorithms in there, and sensible algorithms. Like Maya was talking about, cluster randomized trials with 32 communities. We actually did do a TMLE, what Maya was referring to Laura Baltzer's work, where we did do a TMLE with a superlearner, believe it or not, but it wasn't a superlearner, with 15 algorithms, but all of them using only 1 or 2 variables. So at the end, all of these algorithms did make sense given the sample size, and that's how there was a substantial gain in efficiency doing this. And similar, when you have rare outcomes, you want to make sure that even when you have 5,000 observations, if the outcome is very rare, so that there are only 50 cases, then your effective sample size is more like 100 or 150. So you want to use care in how you choose your machine learning algorithms, so that they are not overly aggressive given what they can work with. Another important thing about this library is that it should contain a range of algorithms going from parametric to highly non-parametric, to the point that it's still reasonable. And so that at least the cross-validate has an opportunity to choose the right kind of level of data fitting for this initial estimator work. And we talk here about both outcome regression as well as treatment mechanisms, sensing mechanisms, and so on. Another class of algorithms we have developed over the last a few years ago, which is highly adaptive lasso. And that's a particularly appealing algorithm because of its theoretical properties, but also of its practical performance, and also because it is actually a very, it's kind of does minimal fitting for a given complexity. So it's very robust algorithm. We'll talk a little more about that. I personally like the discrete superlearner, where we just choose the best instead of the best weighted combination, but then include in your library. You can still include convex superlearners, or which look for best weighted combinations, and in fact, in more recent work, we are actually suggesting to use for the meta learning step something like highly adaptive lasso, which is a much more aggressive way of finding the best functional combination of all these candidate estimators in your library. But then it's indexed by the L1 norm of your lasso meta learning step, and so we will have a whole range of them, and then the discrete superlearner will just choose the best one based on cross-validation. And in this way, we are guaranteed, because the discrete is extremely good selector, very robust, we are guaranteed to find the right level of how to do the meta learning step, right, from very parametric towards highly flexible. The highly adaptive lasso is an algorithm which, it's really a non-parametric maximum likelihood estimator. So you're maximizing, or depending on your loss function, it can be, you can think of it as a non-parametric least squares estimator, or whatever you're trying to do. So the idea is that you are saying, okay, I have this criteria, I have to minimize over all these functions, right? Like outcome regressions, for example, that's a function of the treatment and the covariate. And you have, let's say, a log likelihood or a least squares. You say, I want to minimize the least squares or maximize the log likelihood over all these functions, but under a constraint that they have to be so-called Cadillac, which is right continuous left-hand limit, but moreover, that they have a certain complexity. And the complexity is defined by the variation norm of the function. And I won't get into detail what it exactly is, but in essence, it is what you kind of would think of if you just plot a function and you see how variable, how much it goes up and down, right? And you count that all up. That's kind of a variation norm. And you're saying, okay, for a given a variation norm, complexity of a function, I want the best function which gives the best fit. Now that is, and then we just choose that variation norm, that level, that bound, that complexity. We choose that with cross-validation. So it can still be at the end chosen as large as needed, making the right trade-off of bias and variance. Now this estimator is remarkable. For example, we have shown that it achieves a rate of convergence. That means as sample size grows, it approximates the true function at a rate n to the minus 1/3 up to log n factors. And note here, this is not even looking at the dimension. The only way the dimension of the data kicks in is through the log n factors. So in essence, you get the rate n to the minus 1/3 for every dimension. So if you have 10 cohorts or 20, you get that rate n to the minus 1/3, which is, yeah, that's, I mean, that has all kinds of implications. That means in particular, if you use this highly adaptive lasso either by itself or in the library of the superlearner, you are guaranteed theoretically that these estimators like TMLE are going to be asymptotically efficient. So they follow the theory, at least asymptotically. And then on top, these algorithms are actually also very good in finite samples. What also we have shown about this highly adaptive lasso, it's an MLE, it's a maximum likelihood estimator or minimum loss estimator, and in particular because of that, it solves a lot of score equations, just like a maximum likelihood estimator. And solving score equations means it starts behaving like a normal distribution, right? That's how you analyze maximum likelihood estimators. So this estimator is actually having that property what we are used to for parametric models, that if you use highly adaptive lasso to learn, let's say, your outcome regression, and you then choose the L1 norm, which is the same as the variation norm, because it just uses a big linear combination of basis functions, which are splines. That's what it comes down to. And you choose this L1 norm, instead of doing it with cross-validation, you choose it larger than cross-validation suggests. So there's a little bit of undersmoothing going on. So you choose more basis functions than you would normally choose. Then it actually has the property that it becomes something which is efficient for any features you calculate from that function, like the outcome regression. And yeah, that's remarkable. That means we have now a machine learning algorithm which acts like a maximum likelihood estimator. It gives you normally distributed features of that function. So it's a remarkable, robust machine learning algorithm. So it's not only converging at a remarkable rate, it's also having a remarkable, robust performance in the sense that it gives these approximate normal sampling distributions. And another beautiful thing about this highly adaptive lasso is that you can actually bootstrap it. You can use the non-parametric bootstrap, and you can prove that its behavior under sampling from the empirical distribution is still similar to as if you were sampling from the true distribution. Now, for typical machine learning algorithms, that's not true. And so that's why typically we say don't do the bootstrap when you do machine learning, right? And that's why we do inference curve-based inference. But with highly adaptive lasso, if we do that as our initial estimate and do the TMLE, you can actually fully bootstrap this. And that's good news, because that means you can pick up second-order terms for the inference and get more robust variance estimates. Let's see. How am I going to the next slide? Here. Okay, so let's, regarding dealing with positivity. So like Maya pointed out, you might have a treatment regimen which has poor support. So that means when you do this inverse weighting in your targeting step, for example, involving inverse weighting by the treatment mechanism, you are inverse weighting by this product over time points of conditional probabilities of following the rule, given you have followed it so far. And that product, if for some of these time points that probability is small, yeah, then you're getting this product might get really small. And so you start inverse weighting by relatively large numbers, and that can have all kinds of problems, such as large variance in particular. And so these kind of practical positivity violations, they can result in bias of your estimators, but also can mean that your variance estimator is underestimating the variance. And so a typical sample variance of the inference curve, which is what we normally use, becomes actually a somewhat biased estimator in these situations. So to deal with positivity violations, which means you have kind of weak support for your target estimate, and therefore you're subject to potentially high variance. That makes the estimators having problems and makes it challenging. And so that was also the motivation of doing a substitution estimator. It was the motivation for TMLE at the time. You know, I had worked a lot with Jamie Robbins and others on estimating equation methodology. And that was one of the findings, is that it's just not robust. It's not a substitution estimate. It's just too erratic and beyond other problems. And when you are a plug-in estimator, at least you will always respect, for example, that you're estimating a probability. So you respect the constraints which are about your parameter and also about your data chain distribution. But having said that, you know, it's not like when you do TMLE that suddenly it's not affected by positivity anymore. You still have, it's just not as crazy that it starts giving negative probabilities, but it's still, you know, it's still, it's a problem. And so there are other things for that reason, we have worked on, which is called collaborative target mix and likelihood estimation, where you say, okay, really the problem occurs because we are fitting this treatment mechanism, you know, and in a way that we start including covariates which make these weights blow up. And some of that is, makes sense. You know, you're trying to adjust for that confounder, but that doesn't make sense from a finite sample perspective, right? If you try to adjust for a confounder and by doing that, you increase the variance dramatically and probably not even gain bias, then it was not a good move. And so we really need a criteria, which is not only saying you should look at the fit of the treatment mechanism, you should, but really a criteria how to fit the treatment mechanism in a way that gives us maximal bias reduction during the TMLE step. Now that's exactly what collaborative TMLE does. It evaluates, like adding a confounder to your treatment mechanism or different candidate estimates of your treatment mechanism. It evaluates the performance of it, of how well it works in the targeting step in reducing bias. And so there's a lot of work on this collaborative TMLE, and in particular in these kind of observational studies where things get very challenging and we have these ugly confounders like almost instruments, we see potentially dramatic gains by using CTMLE relative to a blind TMLE, which just says, okay, I'm going to use the best fit of the treatment mechanism, even though maybe I start selecting a covariate which is extremely predictive of the treatment, but really is not helping me at all for bias reduction. That has also resulted in things like outcome adaptive Hall TMLE, where we use first highly adaptive lasso to fit like the outcome regression. And then all the basis functions selected there, these are the ones we bring over to the treatment mechanism and fit so that we are only putting in things which are predictive of the outcome in our treatment mechanism. And in this way, we can still tune that, and that results in very robust TMLEs, which hardly suffer and are much more careful in their bias variance trade-off. And so these are really exciting advances. And then there's also truncation, right? You always want to truncate. You cannot just run a TMLE and say, I'm not going to truncate. Same with IPTW, because that means you allow that one subject contributes, as much as the whole sample combined. And that's just unacceptable. So you need to truncate, like maybe by 0.01 or 0.025, that kind of standard things. But there's also a way to do it adaptively. And we have in particular using, again, this collaborative TMLE criteria to do that in work with Cheng Yu and Josh Schwab. We worked on evaluating using collaborative TMLE to do the truncation and again showing great gains relative to other approaches. So these are the methods, the variations of TMLE or the advances within TMLE, which allow us to at least deal with this positivity violations in an effective, sensible way. But then, as we also said, there's also the issue of variance estimation. That positivity also affects how good the variance estimator is. And so number one, the empirical variance of the influence curve is what we normally use. That should be replaced by the cross-validated variance of the influence curve, meaning you run your nuisance parameter estimates, like the outcome regression, the treatment mechanism, on training samples of 9/10, and you do the sample variance over the 1/10, and then you do that average across 10 splits, and that gives then so that at least it's not we don't get a low variance, because influence curves are like residuals, right? So if you have an overfitted initial estimator, you will be underestimating the variance. It's just like an empirical R-square is not as good as a cross-validated R-square. So that's why we have to use cross-validated variance of the efficient influence curve as a much more robust variance estimator, which is not just going to be small because you overfitted your initial estimators. But then on top, that can still not be enough, because the variance is itself a parameter of interest. And in essence, I'm saying we should be using TMLE when we estimate the variance of our estimator. And in others, we should be using a plug-in estimator, a substitution estimator. And again, that appears to be a very important thing to do, which really, for example, what Maya was talking about, that certain rare things like that, let's say the probability of receiving a treatment for a very healthy person is extremely small, and therefore it doesn't even happen in the sample. That would then cause that there are no large weights. But in reality, if you would have an infinite sample, these things would have happened, and you would have had these huge weights, and they would have contributed to the variance. And a plug-in estimator will pick that up, because it will integrate over all combinations of histories and not just the ones in the sample. And so that's where, again, and that's also implemented in the LTMLE package, and that's a variance estimator which will get large if there is real positivity issues. Another thing we have done, as I said, you can, when you do highly adaptive lasso as your initial estimates, you can actually do the non-parametric bootstrap. And so that allows us to also get wider confidence interval when that makes sense, and also picking up second order remainders. Okay, how am I doing on time? Let's see. Okay, so then there is something to discuss here about this. The TMLE Maya talked about was the sequential, is what we have been using a lot, and many people, is sequential regression. But there are some disadvantages of sequential regression, even though it's very convenient. The first thing is that you start with this first regression of the final outcome given the most recent past, which actually uses the least data. And that regression is going to be the outcome for the next regression. So that means the regression, which is actually the hardest, and therefore also the most biased and uses least sample size, is actually determining how good the next regressions can be. Because if this one is not good, that carries over to the others. So in essence, it corresponds with estimation of a likelihood factor at each time separately. So that's another issue. It relies on a discrete time formulation. Because if you have all these factors of the likelihood over time, and you are estimating them separately at every time point, that means you need to have some events. Like, think about it, you're estimating some kind of conditional probability of what happens at that time point given the past. And that what happens is like an indicator of some type of event. Then you're really estimating that without pulling over time. And so if you have very few events that are happening at that particular time point, because maybe it's a very fine time scale, it starts having problems. And so you really do rely on a finite number of time points so that there's enough happening between these time points. So that's another issue. The other thing with sequential regression is it really is made for mean outcomes, counterfactual means. And you can do it for the outcome at a particular time point, but you cannot target, for example, a treatment-specific multinomial distribution of an outcome at a time point. For example, maybe you have an outcome which has 3 possible categories, like you have in competing risks. Like you have an outcome of type 1 happening, or outcome of type 2 happening, or neither are happening. So these are 3 events. So you really want to estimate the probability on these 3 events under a treatment regimen and under a control regimen, and look at the difference to understand really what the treatment does to this important outcome process. Now these are examples where you can still use the sequential regression by just targeting one probability at a time, but that means you get a non-compatible estimator. And so that is, has some disadvantages and some finite sample issues. And similarly, you also have to separately target if you want to get the whole survival curve, the whole treatment-specific survival curve. Now, these are things which wouldn't be the case if we use actually what we really call targeted maximum likelihood, where you say, I'm just going to write down the likelihood as this product of conditional probability of what happens at the next time point given the past, and I am just going to estimate them. And so and then you have, for every factor is its own factor, you can estimate them separately. It's not like what happens to the loss factor, if that's less precise, that affects the earlier factors of the likelihood. That's not the case anymore, so that's good. They're all variation independent. They can all be fitted with their best possible superlearners. And also you can pool. You can pool across time now. And that means you can actually handle continuous time. So things where maybe people are monitored at times which really are, on a daily time scale. And maybe on one particular day, there are very few people who got monitored, but that's still okay because we can pool across time and still do machine learning in that manner. And so this is work Helene Reitgard and Thomas and myself have been working on building such a TMLE. We had done that in 2010 with Ori Stittelman in discrete time, kind of type TMLE. That one was also a closed form. But anyway, now we have been extended it with Helene and are working on it as well, and also bringing in the highly adaptive lasso to get these longitudinal target maximum likelihood estimators in continuous time. There are also various challenges for scalable implementation. So that's something we also have been thinking about, in particular with Sei Wang and Lars, my son, and others, on really building the tools that we can start handling and make it, and that has big implications for all kinds of problems we are interested in, such as networks and time series, where we have to deal with this fact that these efficient illness curves are not easy, and they can make it very non-scalable to implement these estimators. But there is, again, highly adaptive lasso comes to the rescue. At least that's the approach we are following as a way to actually learn the efficient illness curve with machine learning, in this case with highly adaptive lasso, that we get a real object, and that gives enormous benefits. Okay, so then there's this interesting thing that when you do target maximum likelihood estimation, the theory of it still relies on a second order remainder to be small enough, right? And that means some kind of product of like the propensity score estimator minus truth times the outcome regression estimator minus truth. So that's a square difference or product of differences. So we call it second order, has then to be smaller than n to the minus half. In other words, it has to be small relative to like the standard error of your estimator. And of course, as the dimension grows of your covariance, that's even though asymptotically that's true if you use highly adaptive lasso in finite samples, this term might start dominating. And so the question is there a way to create a TMLE where that second order remainder is replaced by a third order remainder or a fourth order remainder? Now, this has been something people have been thinking about, like there's a lot of work by Van der Vaart and Robbins and so on. And we have done some work earlier on this idea of higher order pairwise differentiability and so on. But none of these methods could do it. But anyway, I think we now figured out how to do it. But it's, again, 100% relying on TMLE. It's not possible outside the TMLE framework. But again, TMLE has this unique thing that you can just start adding extra targeting steps and thereby make create bias reductions. And if you do it in a very clever way, then it allows us to create subtleties, what we think now of as a higher order TMLE, which now only relies on like a third order or fourth order remainder to be small enough. So this is very interesting, exciting work in the making. And I really think this is going to give us an opportunity for, again, improved finite sample estimation and inference. And to just give you a glimpse of this, is my last slide, of some simulations Lars has been doing, where you see, if you, for example, we make the first order TMLE is this one, and the second order TMLE is that one. And we did a simulation where the first order TMLE, uses initial estimators, which don't really get the right rate yet. Like they have n to the quarter instead of smaller. So you see the bias is not disappearing at a root nth rate. But then if you do the second order TMLE, the bias is just negligible completely and it knocks it out. And suddenly you have then actually a situation where the first order TMLE is not able to get inference because it's not close enough yet, but the second order still is, because that relies on this third order remainder. So these are very promising results. Okay, anyway, I'll leave it at that.
Thank you, Mark. We're almost at the top of the hour, but I will open up for a quick question if something is there. I have one sort of little bit of, I don't want to call it concern, or maybe it is a concern, that when you show all these amazing possibilities, is it also somehow creating a new forest? That how is some of the beauty of it being relatively straightforward then disappearing in how do you choose between all these different ways of attacking?
Yeah, I mean, so this is of course always the tension between advancing the research, which is a continuous thing, which is always focusing on making it better and better and better, by trying to understand the weak spots, then starting to think about it. Why is this happening? Is it possible to do better? And that's why we came up with things like cross-validated TMLE, collaborative TMLE, and now this high order TMLE. They're always inspired by saying, can we still do better? Right? Is there a way to do that? And then the beauty is that the TMLE framework has this flexibility. It's not just one method. The TMLE framework is a template. It's a template for constructing of efficient substitution estimates, which can have all kinds of additional properties by doing additional targeting. So it has immense flexibility. Now that immense flexibility is, from my perspective, a very good thing, because it allows us to deal with every challenge we kind of encounter. Having said that, there's also the practitioners, and the practitioners want to just get, kind of a story like, oh, in this type of setting, I should be doing this. Now, I mean, and also our software is sometimes behind, right? We cannot some of these advances are implemented for some, but not for others. And so there will always be this little lack. But at the end of the day, also the software, and certainly when companies will get involved, right, who will start really working on writing these professional programs of software development, and the environment, it's not just the companies, also actually the whole, there's so many now good R programmers, and they start getting involved. So it's not just us anymore, right? All kinds of people starting to contribute to this environment, adding these advances. So things will get better and better and better, also for the practitioners. But I do understand. I mean, we are talking, if you truly want to understand all this, that could be very confusing. But I think at the end of the day, it's good. Because we are making things better. And at the end, provide software which is more robust, more reliable for the people who really have to do this in their work.
I couldn't agree more. It was a little bit of a devil's advocate. But of course, we just have to not forget the point about at some point iterating it into the software. That was actually the best possible way of phrasing it. The thing that actually gets implemented in user-friendly, fully documented software. Now we are at the top of the hour, and I at least have learned very, very much and been very, very inspired from this, not just this day, but all 3 days, and all the speakers. I'm also just delighted to be part of this initiative. I would actually like to close it now. Thank Mark, Maya, Lucas, Andrew, all the speakers. So yes, thank you very much. And for the people on this side of the Atlantic, have a wonderful weekend.
Thanks so much.
Thank you all for joining us.
Yeah, thank you.